I hope you're all here for an interview session, specifically about the clinical stations for core surgical training. Okay, so hopefully you guys will find this useful and interesting, even if you're not applying for core training this year. So I think most of you will know that the presentation is going to be split across 2 days, and we're going to have successful core trainees giving their takes and advice on the stations that form the interview. It'll be interactive, so you can question and answer through the chat box, and hopefully this will help you prepare for the real thing. So today we've got Will and Sadia, who are both CT1s at Airedale, and they will be doing the clinical stations for you. So yeah, you've already moved on to the next slide. So our kind of main aims, you know, as we mentioned in the portfolio session, I don't know if any of you attended that. Obviously, core training applications are sometimes daunting and they require a lot of hard work. And a lot of people do possess the passion and drive for the specialty, but they fall down when they're making the applications. So I don't know if you guys are all applying this year. You must have all heard about your interviews, or you're hearing about your interviews in the next couple of days. But it's always useful to know kind of what to expect. So hopefully we can help you with that. If you can move on to the next slide for me, Will. Okay, so there's just something missing in this. Oh, there we go. Yeah, so logistics of the interview. So this is the second year that they're running it online. The interviews are going to be run from the 7th of February to the 18th. It's obviously virtual. So the way that it works is it's obviously online. You get a Microsoft Teams link, I think. And essentially you sit in a waiting room, you speak to someone who's the administrator who is in the interview, but you don't see them. They just administer, they tell you the timing. So they tell you, okay, you've had 3 minutes for your leadership speech, now move on. So you see the administrator, they ask you to put your computer around so that they can see that you're not got any materials, so you might be cheating, or they just ask to have a look around your environment. And then you wait for a little bit more, and then you go straight into it. So it's you start off with your 3-minute leadership speech, and I'm not sure whether they've given out the question yet already, but we'll cover that in the next teaching session. But you go into your leadership speech, and then you have 3 minutes of that. You're told by the administrator when you get your 3 minutes, and they start on 2 minutes of questions about leadership. Then you have a station on management, and that's 5 minutes. Then you immediately move on to clinical scenarios. So there'll be one that's ATLS and one that's CCRISP. And ATLS stands for Advanced Trauma Life Support, and CCRISP is care of the critically ill surgical patient, if you guys don't know. And you have 5 minutes for each of those, and then the interview's done. So it's really, really quick. And hopefully, if these sessions can give you a bit of a flavour, a bit of preparation for the interview itself. So I will leave you with Will, who's a CT1 in Airedale, and he's going to be covering the ATLS portion, and then we'll move on to CCRISP, which will be a different CT1, and I'll introduce her later on. So yeah, Will, you can get started.
Brilliant. Can you hear me?
Yes.
Brilliant. All right. Hi everyone. So my name's Will. I'm a CT1 in Airedale. Just started this year. And it's going quite well. It's pretty fun. Yeah, I found this interview really daunting, and it was a really scary experience. But I think the most important thing for me was just practicing. So I'm just going to go through the ATLS part, and then the things that I picked up on tips and tricks and what other people taught me. So I'm just going to go through the resources I used, things that help you try and stand out in the interview, the general overview of ATLS, things to try and avoid, and then we'll just do a couple of questions at the end. One thing to mention is that, like, when I did this, I hadn't done ATLS at the time, and none of the people I was practicing with had either. So it doesn't actually make a difference if you've actually done it or not. In terms of resources, So things I use this green book, which you can get off Amazon, and just went through that multiple times. Another thing is if you go on surgicalinterview.co.uk, that's a handbook created by previous trainees, and they've just gone through loads and loads of examples, and they're based on previous things that have come up. So that's a good one to go through as well. In terms of specifics for ATLS, try and get your hands on the manual. So find someone who's been on the course and get sent the PDF. And then also another thing to go through is like all the guidelines that are particular for trauma, for example, like the BOSE guidelines. So have them printed out for all the specific kind of things. So if you get specific questions on those kind of things, you can just answer them straight away. So the most important things for me for tips and tricks would be to buddy up. So I presume you guys have all been practicing already if the interview is fairly pretty soon.
Oh my God, thanks, Pablo.
Sorry, is that a question? No, I'll just carry on then. Is that a question or not? No, I think it's just someone's microphone was on. Anyway, so yeah, tips and tricks. Most important thing is just knowing it 100%. So for me, I wrote out a blurb and just went over it 100 times and just made sure I knew it inside out. Because in these questions for the ATLS and the CRIS, time is everything. So this is going to be where you're going to pick up most of your marks, and you want to be aiming for 100% in these kind of questions. So they're easy marks, and as long as you've gone through it 100 times, then you should get the marks. And the key to doing that is just going over mocks over and over. Get random people to do mocks with you. So ATLS, as you know, is there's a general scenario, and they ask you to present to review the patient, and then they go through some questions and answers. The main areas that you get marked on are clinical skills and knowledge, judgment, and communication. And you've got about 5 minutes. The most important thing is to get your blurb, your initial intro blurb done within about 60 to 90 seconds to give yourself lots of time for questions. So just going to talk about what ATLS is. So it's the primary rapid survey with simultaneous resuscitation of vital functions. As you're aware, there's A, B, C, D, and E. And these are the steps you're going to go through basically when they ask you to assess the patient. So what I'm just going to do now is just go through just the scripts that I wrote out. You might find it helpful, you might not, so just feel free to ignore or listen to this. But these are the key things that I went through, and I've just highlighted the things that when you're doing this, the first line is the most important because you've got to get their attention straight away. And if you get their attention with within the first 20 seconds showing that you're competent and you're in control and you know your stuff, then they'll just probably switch off for this bit of a blurb and then come back to you at the questions. So the most important thing is knowing this kind of stuff inside out. So for me, the most important thing is a nice opening line. So for me, I just went for this patient is sustained, so like highlighting the major trauma. They need to be assessed using the A to E approach, using the ATLS protocols in a resus environment. So those are the kind of key things just to put in that opening line. And then I just went through the A, B, C, D, E. I just tried to keep it as sweet as possible. So I won't read this out. I'll let you read it in your own time. And I'm sure there'll be a copy if you need it. But this only takes me about 60 seconds to go through, and I would just learn it exactly pretty much. And then I would recite it out in the practice with my friends for the mock. And then the most important thing is to once you know it 100%, then you can add in specific things to the question that will try and help you stand out, which we'll go through in a second. So just to go through this in a bit more. So the key things to highlight are things like triple C spinal mobilization, trying to look for immediate airway compromise and managing that. Things like palpating the trachea, and then highlighting that circulation is alongside hemorrhage control, and just going through these general points. So in terms of the extras, when you go through it, so my plan was just to learn this, and then specifically the most important thing is to listen to the question, and then depending on what information they give you, then you can add in extra stuff. So this is all from the ATLS trauma manual. So for things like airway, if you've got epistaxis or they mention blood at all, then you can just mention things like suction, which will help you stand out in the question. If they mention that the patient's got low SATs and they've got chest trauma, then you would mention these kind of things that you'd be looking for during your examination, to try and highlight like life-threatening injuries. And if they mention any bleeding, you might try and stand out, you're looking for internal, external bleeding, and looking for these points of things. So these like chest, abdomen, pelvis, long bones, which is on the floor and 4 more. So these kind of things you want to be adding in dependent on the question with your initial blurb. So if they mentioned the patient was had a low GCS, you might mention that if they've got a GCS less than 8, you would intubate and ventilate. And then for exposure, you want to make sure that you're always exposing the patient. And then tips and things like that is to make sure that you always maintain dignity. So I was just going to do a mock if anyone wants to volunteer, and I'll put it on for see if they can go through it in 90 seconds or so. Does anyone have a go? Fine, I'll pick someone. And Abdullah, are you willing to give it a go? Abdullah, are you there?
So there are people their hands up. So if I think I can see someone, Shirley, you can have a go.
All right, Shirley, I'll put the timer on. I'll give you a couple of minutes. So have you got your microphone on, Shirley? Hello?
Sorry, I don't know if the microphones are working. I've just tried to change it, but my internet has stopped working. Crap.
No, I can't hear you, Shirley. Let's see if we can see if you click on.
Right, I've changed it so you can do it now, Shirley. Sorry.
Yeah, I can unmute myself. Yeah, can you hear me now?
Yeah, we can hear you now. All right, I'll give you about 2 minutes, Shirley. So you've got a 45-year-old male who's been involved in a high-speed RTC, and you've asked to see him in A&E majors, and he's complaining of leg pain. How would you assess this patient?
So a 45-year-old male, he's been involved in a high-speed road traffic accident and complaining of leg pain. How to assess the patient? All right. Can I start now?
Yeah, you can go for it.
Okay, so this patient obviously has sustained a high energy trauma, and I would start by assessing this patient in using the ATLS protocol, the ABCD approach of the ATLS protocol, ideally in a resource environment. I will start by assessing the airway and making sure that the C-spine is immobilized, because he's been involved in a road traffic accident, and even though he's complaining of leg pain, he could have also sustained other major injuries. So airway, making sure the airway is patent and he's maintaining his airway. If he isn't, then I'll use airway adjuncts, and also have in mind to contact the anesthetist in case he needs more definitive airway. Also immobilizing the C-spine using the triple collar, blocks and tapes to triple immobilize the C-spine. At this point, I'd just like to mention that because it's sustained a major trauma, I also like to put out a major trauma call involving the anesthetists, the surgeons, and every other person who would be of help. Moving on to the breathing and the ventilation, I would like to put on high flow oxygen. That's 15 liters of oxygen using a non-rebreather mask, and connect this patient to monitors to monitor the saturation and the other vital signs. I'll also look at the trachea, see if the trachea is central. Also inspect the chest for any injuries, any open injuries on the chest, look at the breathing, the chest wall movements, also percuss and auscultate the chest to rule out any other injuries like a hemothorax or a pneumothorax, any other thing. He could have any other injuries because he's been high speed injury. Moving on to the circulation, I'll make sure that I have IV access using 2 white ball cannula. And from 1, take bloods for baseline bloods, clotting, group and save, and a VBG, or venous blood gas, or an arterial blood gas, as the case may be. Also start some fluid resuscitation with warmed crystalloids, depending on the patient's blood pressure. I'll also try to examine the capillary refill, the blood pressure, check what the blood pressure is, and look at the temperature of the extremities. Still in C, I'll just quickly examine the abdomen to make sure he isn't bleeding anywhere else. Look at the floor, look out for any bleeding points. And if there is any, then I could control the bleeding using direct pressure. If that doesn't control the bleeding, then we can move on to other things like tourniquet application and any other thing that could control the bleeding. Moving on to the D, I would like to assess this patient's consciousness level using the Glasgow Common Scale. I would like to examine the pupils, checking out for the pupillary reaction, the size, and also checking for any lateralizing signs. I'll also want to check what his blood sugar is. And then exposure, I'd like to do a head-to-toe assessment of these patients. I'll also check the temperature while maintaining dignity and making sure that he doesn't become hypothermic as well. After all this, I'll just like to add that I'll also put in a urethral catheter to also monitor the fluid resuscitation that we're giving and the.
All right, I'm going to stop you there, Tilly.
Okay.
So that you went through most of the points, which is really good. The only thing that I'd probably highlight is that the time. So I think you took quite a while, so I'll let the clock run. So the most important thing here is to know you know all the information and what to go through, but it's to try. You need to practice and get yourself under 90 seconds really for this kind of thing, because if you take your time on that, they're not really, people aren't going to be, as long as you hit the major points, you sound slick, no one's going to be picking up on the really minor details. Like I hadn't even really clocked, you hadn't put in a catheter or things like that. But it's just to make sure you hit the main points and you're slick within about 90 seconds. So you know all the points, but just time yourself and practice getting it into 90 seconds, because a lot of the marks will come in the questions. So you want to get through to that point for then to be able to answer the questions. Does that make sense? So if I just go back to this one. So yeah, you went through pretty much everything, but just try and be a little bit slicker and just do a little bit more practice to get it under 90 seconds. But you hit all the points.
All right.
In terms of the question, we've had 5 minutes there. So the question I would have asked was, so the patient's stable, and you haven't found any life-threatening injuries, and they're alert and they're talking to you, but he's got an open fracture of the leg, which is quite obvious to you. How would you manage that?
So after going through the A&E, he's got an open fracture. I will manage this according to the BOST guidelines, and that will be to. So if there is any, you can try to reduce the fracture. If it's not reducible, reduce it. Dress the wound with and put it in a splint, and dress the wound with a saline soaked gauze. Start this patient on antibiotics and tetanus injections depending on their immunization history, and consent them and work them up for surgery to have the fracture fixed.
Brilliant. So you got that. So most important thing, you mentioned that you want to be short and sweet. Mention the BOST guidelines, antibiotics, tetanus, all that kind of stuff. Saline soaked gauze. Just be a little bit shorter. But yeah, that's the main points. So yeah, thanks for volunteering, Shirley. That was really, really good of you. Just because we're a bit short of time, I'll go through the next one if that's all right. Got one more to go through. Have we got any other volunteers?
I can try for this one. Well, if you can hear me.
Yeah, that's fine. All right. Do you want to? I'll put the timer on, and I'll go through it with you. Fine. So, you've got a 58-year-old female who's fallen down 20 flights of stairs. She's been brought to the hospital by the ambulance department, and you've been asked to see the patient. How would you assess this patient?
All right. So this patient, 58-year-old female, has sustained injury from a fall. I'll be suspecting some trauma, and hence I'll be managing her using the ATLS principles. I will be doing an A to E assessment and ideally identifying and managing conditions in a rhesus environment. For A airway, I will initiate immediate C-spine restriction using collar, block, and tape. I will then look and feel the airway and manage it accordingly with adjuncts. For breathing, I will determine the respiratory rate, oxygen, start high flow oxygen, and then look, listen, and feel the chest and the neck through inspection, palpation of the trachea, auscultation of the chest wall, and percussion of the chest wall.
Okay, brilliant. So you've done that part of the assessment. The patient's sats are dropping, the respiratory rate is increasing, and you notice they've got deviated trachea on the left side and reduced breath sounds on the right. How would you manage this patient?
Given the respiratory distress and respiratory compromise and the signs of a deviated trachea and reduced breath sounds on the right side, I'll be suspecting tension pneumothorax on the right side. So initially, as I've managed B with oxygen on the patient, I would then try to start needle decompression of that area to see if there's any hiss of air and confirm the tension pneumothorax.
Brilliant. So you've done that, and the patient's stats have increased and the patient stabilized. Please continue.
Now that the patient has stabilized, I'll continue my reassessment of A to E. Once I've done that and I'm sure that the patient is stabilized, actually mentioning C, I will make sure that they're stabilized from a circulatory point of view by checking the blood pressure, heart rate, doing a shock index, and then putting 2 large bore IV cannulas, where one would be used for FBCs, UZNEs, LFTs, and a group and save in case it's needed, and then 1 cannula for a fluid bolus of 1 liter of warm crystalloid in 1 hour. I will assess for bleeding and take it from there. If needed, I will cross-match 1 unit of RBC and start the massive transfusion protocol if needed. I will complete D by doing a GCS, glucose, and neurological signs, and E by doing a full examination from the head to toe by completely undressing them and while keeping normothermia with warm fluids, blankets, and a room. Given that she sustained tension pneumothorax, now that we've decompressed it, I will get the patient ready for a chest drain on the right side as a form of definitive management. I will inform my registrar and my seniors of this.
All right, brilliant. Okay, that's pretty much it. How would you differentiate? Does anyone else want to answer a question? Just to open it up to the floor. Fine. I'll continue with you then, Abdullah. So how do you differentiate between a tension pneumothorax and a massive hemothorax?
With pneumothoraces would cause a deviation to trachea towards the contralateral side and will cause reduced breath sounds on the ipsilateral side. However, tension pneumothorax will cause resonance, hyperresonance on percussion on the ipsilateral side, while a massive hemothorax will cause dull percussion on the ipsilateral side.
Brilliant. Yeah, well done. So yeah, you've been through most of the points there. We're fairly quick with your blurb, and you went through everything. The thing here to kind of highlight is that when you have this ATLS, you're either going to just be asked to assess the patient, and then they won't stop you, or you'll do an ATLS. And they'll stop you at points during the thing. The only thing to mention there is that after you've done the chest drain, you always need to reassess. So go back to A, B, and start again. So you'd probably do that, and then they'd say, yeah, A, B are fine, continue with C, and finish the rest of your assessment. So whenever you've done an intervention, just make sure that you reassess. It's really important that.
Okay, thanks a lot.
I'll just run through a few the classic questions that that generally come up. But if you go through those, the book for core surgical interview and also the other one, the one online, then all of these you'll be getting up and you'll know 100%. So the kind of things that you want to be looking for, knowing like off by heart, like things like the life-threatening injuries that can be identified during a primary survey. So that's the mnemonic ATM-FC. Things like what adjunct can you be used during the primary survey. So make sure you know all these kind of things 100% off by heart. And what are the different hemorrhagic bleeding sites? So you've got on the floor and 4 more, and external. So in terms of tips and tricks, my main thing would be to go through, get your hands on that ATLS manual and go through it. And always mention recess environments. So one of the things on that first one was that I said the patient was in majors, and Shirley, you picked up on that and you said this patient needs to be assessed in recess. Also things like if you've got a phone call, then whenever you get a phone call, just mention I would take an S-bar handover and then attend to see the patient immediately, and then kind of those kind of things. Also to make sure, be aware of in ATLS there are other steps before the primary survey. So hospital preparation, hospital phase, and triage, which are covered in the ATLS manual. If anyone doesn't have it, you can email me and I'll send you over the manual. Also, so the most important thing for me would be just to learn that blurb like 100% off by heart, get it down in getting through all those points in 90 seconds. And then once you're so comfortable with that, you can listen to the questions and then add in things depending. So if they say things like the patient's tachycardic and their blood pressure is dropping, how do you assess the patient? Then you would mention things like bleeding sites, and you'd be looking for internal and external bleeding. These kind of things help you stand out a bit. Things to pitfalls is C-spine immobilization. Always remember that, and don't take it off. If anyone asks you, "Oh, can you take off the block and collars?" Just say no until it's been radiologically and clinically cleared and you've discussed it with the seniors and things like that. Always reassess after any intervention. Make sure you always escalate and involve specialists. So if you've got a complex patient, because the point of this is just you're just assessing the patient, but you'll be escalating to your registrar and involving the specialist. One thing I haven't mentioned is who's involved in a trauma call. Sometimes this varies between hospitals, but just be aware of there's someone doing the primary survey, there's someone documenting, there's someone leading, there's someone for the secondary survey, there's someone taking bloods. There's lots of people involved, but your job here is just to do a primary survey, and then be aware of the specialists that you can kind of involve. So if neurosurgery, cardiothoracics, when you've got a problem, if you listen to the question and they mention something that's cardiothoracic or neurosurgery orientated, like a GCSS, you might mention those kind of things, just tweaking them in the answer at the end to try and just make you stand out a little bit more. Also simple things like if the patient's complaining of pain, make sure you mention analgesia, and also if you're going to expose the patient, make sure you retain dignity and things like that. Those little things go a long way, just to make you're thinking about the patient as well, rather than just going through the blurbs. Those kind of things will help you stand out. So overall, the most important thing is just efficiency. The ATLS is not there to trick you. They're not going to be mean unnecessarily. The most important thing is just have your blurb sorted in 90 seconds and just practice with a friend or friends and just do it, all over. So I went through that green book 3 or 4 times with one other friend, and we just did it inside out. And and you just got to be really slick, because the most important thing to get the marks is to get through that first bit. So for mine, they just went through, they just let me go for an ATLS. I just did the blurb, and then they asked me 3 sets of questions, and then we'd finished with about a minute to go. So if you can get through it, then you can try and pick up all the marks, ideally. Has anyone got any questions?
There have been a couple of questions in the chat, so I'll just speak through them in case people can't see them. So someone's asked, will the interviewers interrupt you in between your answers, or just let you rattle away and only ask questions at the end? And it really just depends on the interviewers, I'm afraid. So some of them will sit there and look at you and let you waffle on, and they won't stop you, and then your time is over. And you've only scored 20% of the marks, because there's 5 questions, or there's 5 or so questions that they'll ask you. And some of them do actually interrupt you and say, okay, we're moving on to the next question, because you've already gained all the marks that you're going to gain in the first stage of that question. So I think it's just like Will said, it's really important to be concise. And if you've said something, don't say it again. What's the point? You've already got the marks for that. So yeah, it's about being concise and hitting those points and making sure that you've got all the marks. And then someone's asked about, after needle decompression, can you say that you would do a chest tube and then to circulation disability exposure, everything else? And as part of the ATLS protocol, you would do needle decompression, then you would say, I would reassess airway and breathing, and they would say, yes, fine. And then you'd say, I would obviously, as a definitive management, insert a chest drain. So yeah. Regarding the bleeding site, do you mention it in C or E? So you would mention it in C. As part of your primary survey, you'd mention it in C. And then, is there any other questions? No other questions, but yeah. If anyone else has any questions, you can put your hand up. Or type it in the chat, but we'll move on to the next, unless you have any other further pearls of wisdom, Will.
No, not really. I think one of the things is just don't overcomplicate things. Like those, like I remember just asking all those kind of questions, just rattling through for like trying to really go through the minor details. But the most important thing is just keeping it simple. And just go through the major points, and they're not there to trick you or anything like that. So and don't be intimidated by the interviewers, because some of them will just look really bored, and they're not interested, and you think it's gone terribly, and some will like interrupt you. But just just kind of, as long as you're doing your things right, then it's you're going to get the marks. It doesn't matter what the interviews are doing.
Excellent. Thank you for that, Will. That was really useful. So we'll just move on to Sadia, who will be doing the CCRIS part of the clinical station. So if Sadia can please share the slides, if you're able to.
Can you guys see the slides?
Is it okay if you share them? Because obviously Will has his night shift to get to.
No, I'm sharing it.
Oh, right.
Can you see it?
I can see my face.
Okay.
I don't know. Stop sharing.
Yeah. If you stop sharing, Will.
Yeah.
And then
that should work.
There's probably just a bit of a delay because of the internet.
Can you see it now?
I can't see anything, but I don't know if other people can.
Can anyone else see it?
We can't see anything.
What about now?
No, are you using the? Oh wait. Oh, yes, I can see something. Yes.
Great. Can everyone else see it?
Yes.
Yes.
Okay, just to introduce myself, I'm Sadia Khan.
Sadia, sorry, if you make it large, so you click on slideshow. Sorry.
No, it's all right.
Excellent. So I'll let you introduce yourself.
Okay, so I'm Sadia Khan. I'm actually an international medical graduate, and I'm in my TNO placement in Airedale General Hospital at the moment. And I'll be covering the CRISP area, which is care of the critically ill surgical patient. I'm pretty sure if someone's done an F1 and F2 or doing an F3 job, you've seen these patients on the wards and basically know how to manage them. So we'll just go through some of the basic points. I think Will's already mentioned what points they look out for and what you get marked on. So clinical skills and knowledge, that's 12 marks. Then your judgment under pressure and prioritization is also 12 marks. And your communication is 12 marks. And the panel consists of 3 people, 2 of them which are medical professionals, and 1 is just a non-medical professional for non-bias. Each station is 5 minutes, so the total for each station will be 36. So for your clinical stations, you will get a final score out of 72. For any interview or any station that you're doing, just make sure that you have a clear structure, whatever words or phrases you want to use, just make sure that you know it by heart and you get it done within the first 5-10 seconds. Make sure you do it in a structured way. You do an assessment, you think of the differentials or definite diagnosis, do the investigations, and then follow the management plan. Always use an ABCDE, CRISP, or ATLS approach while answering your questions. Do not forget the differentials, even if it's a very, very obvious diagnosis, because they will ask you about them. And for CRISP, it's very important that when you are reviewing a patient, you check everything else that can be seen in a patient, like their ops chart, what's their past medical history, what's their social history, surgical history, what's the drug chart. And it's very important to check the operation note always if it's a post-op patient. And you can always check allergies as well if you're thinking of giving some kind of antibiotics or medications. It's never a bad idea to escalate early or appropriately, but always make sure you've done an initial assessment and have a differential in mind and have a management plan before you do. And once you decide to escalate, make sure you have a concise and structured response, probably an S-bar kind of structure. And what the panelists usually look for is someone who's a safe doctor, because you are going to be a junior doctor. They don't expect you to be doing surgeries at this point, but they just want someone who's safe and confident and someone they'll want on their team. Even if you are unsure of a station and if you think you've never heard of what this problem is or what the differential diagnosis or the diagnosis may be, as long as you're confident and you do your ABCDEs, do the initial management, it should be fine. So for CRISP, this is just from the CRISP book. This is the system of assessment. So CRISP basically is you give a prompt, simple actions, which will prevent any further complications, because once it starts getting complicated, it starts getting out of hand. So it's just the earliest thing you can do to help a patient or save a life. So you do your initial management, which is your A to E. Then you do a full patient assessment, like I mentioned. You do the charts review, you have a look at what the results are already available and what's the patient's presenting complaint, what's their baseline has been, and what was their examination pre and post-op, if there was any. Then you decide and plan whether this patient is stable or unstable. So if the patient's stable, then of course you can just continue with the previous plan. But given that it's an interview scenario, the patient is going to be unstable. So you will have to do other investigations or management and come up with a diagnosis, and then decide whether now this patient needs a surgical, medical, or radiological care. And after you do any intervention, just remember to reassess the patient. So anything you've done, if you've given oxygen, make sure you check the stats. If you're listening to the chest, you're probably not going to do a chest tube in a CRISP patient, but if you do it, get a chest X-ray, reassess. So always remember to reassess after you've done anything. So we'll go on to a mock now if anyone wants to volunteer. If not, I'll probably just pick up the luck because he's the only one I know.
So we have Rayan.
Yeah.
Hello.
Hello.
You're right, Sadia?
Hey, Ryan Sagir. You're right.
Yeah, not
Okay.
too bad.
Okay, good. Are you okay? So the mock in the interview would be read out to you, so you won't actually see it on the screen. So make sure you're listening properly. And
Okay.
and sometimes they'll ask you to repeat it if needed, if it's a very long scenario, or they'll ask if you're happy to proceed, and then you can start with it. So for this one, you get a call from the nursing staff saying there's a 50-year-old lady who is 5 days post-op right hemicolectomy. She's now complaining of abdominal pain. She's tachycardic at 110. She spiked her temperature at 39 degrees. Her rest rate is 18. Her SATs are 97 and has a blood pressure of 100/80. How would you start your assessment for this patient?
Okay. This patient appears to be in septic shock. I would like to immediately assess the patient following CRISP protocols and following an A to E manner. I'd start off by assessing the airways, making sure it's patent. And if the patient is speaking to me, I think that would indicate that the airway is patent. I'd assess the breathing, check the rest rate, oxygen saturations, place them on 15 liters of non-rebreathe to titrate their oxygen saturations if needed. I'd have a look, listen, and feel of the chest. And if their breathing is okay, I can then move on to C. I'd like to recheck their heart rate, blood pressure, cap refill time, JVP, order for an ECG to happen with a heart rate of 110. I'd like to place 2 large bore cannulas if they already are not in place. I'd like to start a warmed crystalloid IV fluid bolus challenge because they've got a decreasing blood pressure. I'd like to take some bloods as well, which would be FBCs, USNEs, LFTs, clotting, CRP, with the rising temperatures and blood cultures as well. Also, a group and save could be useful as well at this point. If A, B, and C are okay, I'd like to move on to D, do a formal GCS assessment, recheck the temperature if it's still spiking, and also assess the pupils. And lastly, I'd like to expose the patient with dignity, assessing if there's any wound, assessing the wound in particular, if there's any erythema around it. Is it a superficial infection? Is there a deep infection? Do a proper abdominal examination, check for signs of peritonism, and from there, I'd like to then maybe take an ample history of the patient and go back to the notes of the patient if they are stable and hemodynamically well enough to read if this is an acute deterioration, check their news score, their OBS, check their drug chart, read the op note, their previous notes prior to this, and also if I'm thinking it's sepsis 6 needs to be started immediately. So that would be IV fluids. I've taken the blood cultures initially. I could make sure we could do a urinary catheter, start some IV antibiotics, broad spectrum, do a blood gas for lactate, and also they're already on some oxygen as it stands. If all this is completed, I'd like to then escalate this patient to my seniors, so the surgical reg on call, do an SBAR handover, let them know what's going on. If it requires any further imaging for this patient, for instance, a CT abdo-pelvis, for potentially what I'm querying is maybe some sort of anastomotic leak, or for instance, some sort of deep intra-abdominal collection, or even bowel ischemia, some possible differentials, and potentially prepping this patient for theatre.
Okay, that's pretty good. There would be some questions from that. So when you say you're going to check the op note, probably the panelist is going to say, yes, they went for a hemicolectomy. And because you cannot just, you can think it's an anastomotic leak, but you don't know if the patient has a stoma or not. So when you check the op note, just wait and see what they say about it, because they'll usually tell you that, yes, the patient had primary anastomosis. So you're right to think that it's an anastomotic leak, but they'll think, okay, it's septic shock. Where do you think it's coming from? Besides an anastomotic leak, what are your differentials?
Sure.
Yeah. So then you'll have to tell what else could be. So if you think about what could be the reasons of post-op fever.
Yeah. So for instance,
yeah,
as I was mentioning, some sort of if it's not the wound itself, for instance, like a more superficial cellulitis or some sort of infection like that. Got things like more of an intra-abdominal collection of some sort. You could also have chest infections and UTIs.
Yeah.
COVID, even in COVID, could be a potential differential.
Exactly. Yes. So, like I said, from this scenario, it's quite obvious that they're day 5 post-op right hemi, possibly an anastomotic leak, but you cannot be very sure unless you've ruled out the other causes of sepsis as well. So that's what they like to hear as well, that you're not just thinking about one, but you're thinking about the differentials as well. So when you're getting the chest x-rays, like need to rule out pneumonia, HAP, whatever, or even COVID, or once you put the catheter out, send an MSU just to make sure there's not a urinary infection, wound infections, stuff like that. So that's pretty good. Broad spectrum antibiotics, which ones are you going to give?
Usually I'll follow the local trust guidelines. Most of the time it does tend to be IV tazocin, maybe. I've come across.
So yeah, I think the correct answer would be to say I'll just follow the local guidelines and I will make sure the patient's not allergic to anything. So I will check their past medical history as well.
Yeah, that's
so
good.
allergies, do check those out.
Absolutely.
Okay, so you've already mentioned CT abdo-pelvis. How would you tell your senior about this patient?
I'd like to have it would be through an S-bar handover. Shall I do the S-bar or?
Yeah, do the S-bar.
Okay. Hi there, my name is Ray. I'm one of the surgical juniors on call. I've got a 50-year-old female patient. She's a day 5 post-op from following a right hemicolectomy procedure. She's showing signs of septic shock. Her blood pressure appears to be 100/80. Her heart rate is 110. I've started her on some IV antibiotics, and I performed sepsis 6. Is it possible for you? I was hoping to send her for a CT abdo-pelvis to rule out a potential intra-abdominal cause for the sepsis. Is there any chance that you can come and review? And is there anything else you'd like me to do in the meantime? Potentially even prepping her for theatre or anything else you'd like me to do?
So that's good. Well done. So the only thing you have to remember is post-op patient, querying, leak collection, keep the patient in my mouth. Don't forget that. Consent the patient if able. Make sure you check their past medical history in case they need to go on a sliding scale or anything. It's very important that you make sure the patient's prepped for theaters. Sure. Say I will consent if I'm able to. I'm not at the CD1. They don't expect you to consent for laparotomies anyway.
Okay.
Both the patient, let the anesthetist know, and mark the patient if they need marking for an abdominal surgery. You don't need to mark the patient. But well done, Ryan.
Thanks, Adi.
Yeah, good job. Any questions?
How far do you take it? Do you think or do you think they'll interrupt you after like you do an initial A to E?
Yeah, so they probably, like during my interview, they all had poker faces. No one interrupted me. They would just like stare at the screen, and I would just keep on going and going and going until I came to the end, and these were the questions they asked me.
Okay, fair.
Because if you've covered everything, they'll probably, but I did mention my differential. I said, okay, this is day 5 post-op, probably a anastomotic leak, but I cannot be 100% sure unless we get a CT scan. So I need to keep the differentials in mind as well. So I mentioned all of that, and they asked me how are you going to hand it over to your seniors, and then how would you do an S-bar? Because if you've mentioned everything else, they'll have to ask you questions if there's some time left, because you also speak really fast, and I was speaking really fast in my interview, so they had a lot of time to ask me questions. So these were the common ones. So this was actually one of my scenarios in the exam, in the interview.
Thank you.
No worries. Any other questions? I can't see, so if Abdullah or Mahnur can let me know. Abdullah's texting me saying pick someone else. I'm gonna pick you. Okay, should we move on to the next one? Anyone willing to give this a go?
It's really good learning opportunity, guys. So put your hand up if you're willing to have a go. It's not designed to be, to tear you down or anything. It's just a really good opportunity. So if you can put your hand up, someone new. Sanjeevan?
Yeah, hi there.
Hello?
Hi there, can you hear me?
Yeah, sorry, who's this?
Sanjeevan.
Hi, Sanjeevan.
Hi there.
Right, again, for this mock, they'll read out the scenario to you, and it will go something like your F1's on the ward, and he calls you for advice about a 78-year-old man who's day 1 post-op right hemicolectomy for colon cancer. The patient is now becoming increasingly confused, and he has a past medical history of type 2 diabetes, hypertension, and heart failure. Over the last 4 hours, he's passed 70 mils of urine, and he weighs 55 kgs. How would you assess this patient?
Okay, so I've got this 78-year-old gentleman who's day 1 post-op. As he's got very minimal urine output, which is below the recommended 0.5 mils per kilogram per hour, I would think he's acutely unwell and assess him with CRIS protocol with an A to E fashion. I start with by assessing his airway, check to see if it's patent and if he's able to speak to me in full sentences. Once I've decided the patency of the airway, I'd move on to breathing. I would assess his chest using a look, listen, and feel move procedure. Auscultating the chest, looking for any crackles which might suggest infection or any other such as a pneumothorax. I would check his oxygen saturations and put him on 50 litres of high flow oxygen via a non-rebreathable mask and check his respirate. For moving on to circulation, I would check his blood pressure, heart rate, and capillary refill. I'd make sure he has 2 large bore cannulas. I'd use one to take bloods, including FBC, using the CRP, bone profile, lactate, group and save and cross match, and as well as giving him IV fluids in bolus formation of 500 to 1 litres of normal saline. I would also insert a urinary catheter, which he already has, to continue monitoring his urine output after the fluid challenges. I would also palpate his abdomen for any abdominal tenderness following the right hemicolectomy, see if there's any signs of peritonism, look at the wounds for any signs of infections amongst it. I'll then move on to disability, checking his conscious level by assessing his GCS, looking at his pupils, checking his blood glucose, before moving on to exposure and checking the rest of the patient in the head to toe fashion. Along with this, I'd also check the patient's observation chart, news chart, his operation notes to see if there's anything difficulty in the operation, as well as his regular medication to see if there's any cause of his confusion. And I'd have to do a full confusion screen, including bloods, chest x-ray, CT head, urine dip to rule out any other causes of infection.
Okay. So your blood results are back. The inflammatory markers are okay, but you notice that his potassium 6.2. How would you manage this patient?
Okay, so since his potassium is above the normal range, I would want to reverse that. So I would first stabilize myocardium by giving him 10% calcium gluconate over 10 minutes. I'll then write up insulin dextrose protocol with 50% dextrose, 50 mils with 10 units of Act Rapid over 30 minutes. I'd also prescribe him some subbutyl nebulizers, perform an ECG, and do serial potassium monitoring to see if he's responded to the treatment.
Okay. Fine. So you've told me that at what point would you ask your seniors to come in?
If I would call my seniors if I felt that the patient was deteriorated or became hemolytically unstable, or I felt that with my interventions or my assessment of the patient, I was not comfortable with how the patient was doing and I felt senior input was needed. I would try and work within my limits, and if I felt my limits were being exceeded, that's when I would also call my senior for assistance.
Okay, Sanjeev. I know this is a really, really easy scenario, but that is not the answer you're going to give about seniors. When you've done your initial management, you will tell your seniors right there and then afterwards. You will let your seniors know about any patient who's acutely confused post-op or is deteriorating, even if they're now responding, but they need to know about a patient who's sick on the ward. So if you tell them that if I feel like they need to know, or if I feel my management isn't working, that's what I'm going to tell them. They're going to probably not give you the proper marks. So always say, like I said, escalate early and promptly. You've done your initial ABCDE, you've done your diagnosis, you've done your requesting, and you've done your initial management. And that's when you're going to call your seniors.
Okay, yeah, that sounds fair.
You've ruled, so this is basically low urinary output post-op. and you have ruled out a pre-renal cause, you've given him a fluid bolus, what other causes can there be for his low urinary output?
So he could also have a renal or post-renal cause.
Yeah, exactly.
Renal cause could be due to acute tubular necrosis, or post-renal could be due to an obstruction of the urinary system, or a block. The catheter itself could be blocked, so it could be as simple as unblocking the catheter or flushing it to see if that helps with the urine output, or ruling out a renal or post-renal cause with an ultrasound, KUB, urine dipstick, and so on.
Well done. So when you were initially managing the patient, you could have first flushed the catheter just to see whether it now starts working.
Yeah.
So just when you are assessing the patient and you're giving a management plan, just try to rule out the pre-renal and the post-renal causes, because then if you do that, they won't have questions in their mind thinking, okay, so he's just given fluid boluses, thinking that this might help the patient. But if you've ruled out, like, hey, I've checked the catheter, it's not blocked, I've given him the fluid bolus, and he's not in AKI, and he's not known to have any kidney issues, but we'll still get an ultrasound to make sure there's no renal causes. I am concerned about this patient. I'm going to let my senior know about him now.
Okay.
Well done. Good.
Thank you.
Good. And any questions?
No, I think it's quite good. Thank you.
Well done. Just involve your seniors early. That is the learning point.
Brilliant.
Perfect. Thanks. Okay. Any questions about these mocks so far? Okay, moving on. So just remember the simple things. Always assess and reassess the patient when you've done any intervention. I've already mentioned that. Check for allergies, past medical history, drug history, previous test results. If you need to make sure, like, patient with post-op low urinary output, are they known to have CKD? Are they known to have any kidney issues already? Were they previously in AKI? Is the AKI now resolving? Maybe it shows AKI 1, but they were probably in AKI 2 before. So it's really important to check previous results and check the op notes always. Don't forget the differentials. Request the test and investigations as required. Just don't order everything. One more thing I would like to mention. In the scenario, they said the patient was catheterized, and then you said, I might catheterize the patient again. So just, I know we all learn all these ABCD, I'll do this, but you need to, it's really good that you have a pattern to go about, but just don't be so robotic about it that you just mention everything. Because I remember once it happened, the patient was post cystectomy, which is removal of the bladder, and someone said, I will catheterize the patient, which is just negative marks completely. During the pandemic, if you mention patient needs to go back to theaters, I'll make sure that their COVID is up to date, because you always, theaters want to know the COVID status nowadays. It's just brownie points if you want to say it. Escalate and ask for help as early as you can and in an SBAR manner. And if the patient needs to go back to theaters, then make sure they know them out, consented if you can, bookmark and inform the anesthetic team. Any questions about your clinical stations?
If any questions, then you can just raise your hand or type it in the chat. I'll just go through some of the questions that have already been asked during your presentation, Sadia. So, I answered a question about, given that you've been told the observations in the example, should you focus on treating these in the ATE, and then that you then go through, because they have tachycardia and hypertension, you'd say that you'd treat them with fluids. So the way that I would structure this, so I noticed in both of those questions, the stem is that, sorry, there's just, I don't know if someone's talking in the background, but you can.
Sorry, that's just me.
Okay. Sorry, I can't concentrate. But yeah, so I noticed that in both of the stems, you're being called. If you're on the phone, you're not going to jump into your A to E immediately, are you? You're not at the patient's bedside. So you will you will get some more information. That's, you know, it's difficult to kind of grasp in an interview situation, but if you're on the phone, you're not just going to go straight to the ward and just say, yeah, I'm coming. You need to prioritize. You need to find out how sick that patient is. You need to know the news. You need to know what operation they've had. Have they been deteriorating throughout the day? What's the trend? So it's not just their current observations, it's what's the trend. Have they got any, do you have a fluid balance chart? You have all these things that the nurses will have. And then you can also ask the nurses or whoever's called you to perform some actions while you're on your way to the patient. So you can ask them to do some blood, so you can put some oxygen on the patient. If their saturations are 88%, you wouldn't ignore that, would you? You'd say, please, can you put them on 15 litres non-rebreathe? And I'm coming down immediately. You know, because in real life, you're going to have a number of things to do, which obviously you guys know because you're F1s, F2s, you do have to prioritize. You're constantly prioritizing when you're on call. So it's really important to get those kind of things down and say it concisely. And then you say, I will go down to the patient. Then they'll probably ask another question at this point. So it won't be that you go, they might just say, okay, fine. Now what would you do? Then you go into your A to E. You've got some observations already, so you'd prioritize. You'd manage each thing from your A to your E, making sure that you don't move on to another thing without treating the thing that you found. And say if there's an airway obstruction, you're not going to go straight on to BR. You're going to make sure that you treat the airway obstruction. And I think it's also important, and it makes you stand out as a really slick, really good candidate. If you say this patient, like the first one, was day 7 post-op for a hemicolectomy, they've had a primary end-to-end anastomosis, that's the optimum time that anastomotic leak is going to occur. So you say, this is day 7 of primary end-to-end anastomosis. I'm concerned regarding anastomotic leak. Like Sadia said, you'd also need to say your differentials. This patient is septic. There are other reasons for this. I'd be concerned about wound dehiscence. I'd be concerned about, post-op atelectasis. It's not just about the operation itself, but other things that can occur in the operation. So I think it's really important to, say what differentials that you'd be worried about, and then, but also making sure that you're answering the question. But yeah, I think that was that question.
Can I just add to that as well? It's always good if the nurse is calling you to ask about, hey, what's the news? But mostly in the scenarios, they'll give you enough information to kind of get to the news. If they're hypertensive, tachycardic, spiking temperature is going to be above 5 or 6. Know that it is time limited, and don't ask a lot of questions, because this is your interview. You're the one meant to be answering the questions rather than asking a lot. So I did ask one of my consultants whether it's nice if I ask the nurses over the phone, hey, can you do this? Can you repeat that? And he said, you can ask to a certain level, like, hey, can you make sure that the cannula stuff is ready, or we can get some bloods on the patient, and I'm on my way. But if you ask too many questions, then sometimes some of the panelists can get a bit, cranky about it, because they're the ones trying to ask you the questions. So yeah.
I wouldn't have asked it as a question to the interviewer, but it's just something that you would consider, something that you would do on a regular basis.
Yeah,
obviously, that would be 10 seconds max.
Yeah.
I would have gone further past that, because you have other questions that you have to answer, and it is only 5 minutes to answer the station. So yeah.
So real life practice, really good. Interview, just remember your time management is basically what it is. So
someone else has asked, can we have a piece of paper and pencil at the interview?
No.
And unless you have specific reasonable adjustments, you can't, unfortunately. So unless you have dyslexia or there is a reasonable adjustment that you can have those things, then I'm afraid that you can't. And you will, if you do need reasonable adjustments, you will have had to already have said it when you were applying for core training. So if you forgot and you haven't done it, they won't provide it for you. And then people are asking for practice buddies. So yeah, definitely message each other. I think that's a really good idea. I think it's a really good idea to just practice over Zoom or Microsoft Teams. That's what I did in the run up to my interview. I practiced with a buddy, went through all the stations that we thought could come up, and it really did help. It helped with kind of speaking and learning about your timings. So yeah, definitely message each other. Is there any other questions? I don't know what the name of the Facebook page is, but I think Carl might. Oh, our Facebook page. Is that what you meant, Carl? Yeah, our Facebook page. Yeah, you can message each other on our Facebook page. That's absolutely fine. But yeah, Sadia, if you don't mind going to the next slide, if there's no other questions. Obviously, if there are questions, you're very welcome to email myself, or I won't speak on behalf of Sadia, but Will has also said that he's happy.
No, I'm happy to answer any questions.
Okay, yeah, exactly. So you'll find us on the NHS, you know, the NHS emailing system. We're all CT1s in this deanery. Okay. What's the email address for the ATLS manual? Oh, someone else has said that you can email. So yeah, so if you guys can provide feedback, it's really useful. It can tell us how we can improve our events, and obviously we've got an event coming up on Wednesday, so we can, if there's any anything that you think that we could do differently. Obviously I think the content and structure will kind of remain the same, because the speakers have already made their slides, but if there's anything logistically you think could be better, then let us know, and please tell us. You know, it's always good to get positive feedback as well, so hopefully this was useful for you guys. And if you can just go on to the next slide, Sadia. Yeah, so this is just our social media details. Like Carl said, you can go onto our Facebook group and make little buddy groups there, so you can practice with each other. You can message us on Twitter as well, and that's kind of how Facebook and Twitter are how we advertise our events. So it's that's mainly where you'll hear about it. We're also doing a surgical specialty series, so just to get you guys excited and interested in kind of specialty training. I know that's a while away, but it's a nice little series of events, and hopefully this was useful. We've got the leadership and management station on Wednesday. It'll be 2 different core trainees who are presenting, and I think it'll be really useful. So I hope you guys found this interesting. If you have any questions, yeah, please just email me or Sadia or Will. We're all very happy to answer anything that you want to ask. And yeah, so our recordings, we have a YouTube channel which we one of our committee members kind of puts them on the YouTube channel. So once she's kind of obscured the names and things, we can put that on YouTube so you can look at it later. So I hope this was really useful, guys. Please fill in the feedback, and have a lovely evening. I'll stop the recording now.